Welcome. Today, we're working through the practical management of persistent pulmonary hypertension of the newborn, pitched at the fellow level. The goal isn't to recite a textbook chapter. It's to give you a usable mental model and a clear order of operations when you're standing at the bedside of a hypoxemic baby who isn't responding the way you'd hoped. We'll start with the physiology that actually changes what you do, move through stabilization, then walk the Vasodilator Ladder, from inhaled nitric oxide through the second and third line agents, and finish with when to call for ECMO. Everything here is built on the 2026 Clinics in Perinatology Review by Mooers, Lakshminrusimha, and Konduri, with the practical points pulled forward. PPHN is fundamentally a failure of the normal drop in pulmonary vascular resistance that should happen at birth. The resistance stays high, pressure in the pulmonary artery stays high, and deoxygenated blood takes the path of least resistance, right to left across the ductus and the foramen ovale. That shunt is why these babies are so profoundly hypoxemic, and why their saturation swings so dramatically with handling. 3 numbers worth holding on to. First, this is not just a term baby disease. The incidence in late preterm infants is 5.4 per thousand, more than 3 times the term rate. Second, and this is the number that drives everything else in this talk, 30 to 40% of babies either never respond to inhaled nitric oxide or lose their response. Third, PPHN is the primary diagnosis behind about 1/5 of all neonatal ECMO runs. On the right are the conditions it travels with. The single most important habit. While you're working the lungs and the vasodilators, you are simultaneously chasing and fixing the cause: the sepsis, the hypoglycemia, the polycythemia, the hypothermia. If you take one conceptual slide from this talk, make it this one. There are only 3 pathways that matter at the bedside, and every drug maps onto one of them. The first is the nitric oxide to cyclic GMP pathway, the dominant one. Endothelial nitric oxide synthase makes NO, which activates soluble guanylate cyclase, which makes cyclic GMP, which relaxes the smooth muscle. The brake on this system is PDE5, which degrades cyclic GMP. So inhaled nitric oxide feeds the pathway from the top, and sildenafil and tadalafil block the brake. The second pathway is prostacyclin to cyclic AMP. Complementary, runs in parallel. Prostacyclin drives cyclic AMP, PDE3 is its brake. That's why the prostaglandins live here, and importantly, so does Milrinone, because it inhibits PDE3. The third isn't about relaxation at all. It's endothelin-1, the constrictor that's elevated in these babies and helps lock in the high resistance. Bosantin blocks its receptors. When you can frame a baby as, this is a cyclic GMP problem, versus I need cyclic AMP support with some inotropy, your drug choice stops being a memorized list and starts being physiology. Before any of the fancy drugs, you earn the right to use them by stabilizing 4 things: gentle ventilation, lower pressures and tidal volumes, optimize PEEP, and permit a mildly high CO2 in the 40 to 60 range, rather than chasing a normal number with aggressive ventilation. Reach for high-frequency ventilation when there's real parenchymal lung disease. Lung recruitment is the one fellows underweight. Remember that both an atelectatic lung and an overinflated lung raise pulmonary vascular resistance and blunt the response to nitric oxide. So you want the lung optimally inflated, and that often means early surfactant for RDS, meconium aspiration, or pneumonia before you ever start a vasodilator. Third, support the systemic blood pressure so that systemic exceeds pulmonary. That pressure relationship is literally what reverses the right to left ductal shunt. Epinephrine, norepinephrine, vasopressin, and consider steroids, weighing the neurodevelopmental risk in preterms. Fourth, get the pH into the 730 to 740 range, but do it without hyperventilation or alkali infusions. Neither improves outcomes, and hyperventilation causes hearing loss. And throughout, fix the underlying drivers. A baby on maximal INO who's still septic, hypoglycemic, or cold is a baby you haven't actually treated yet. Oxygen is your first vasodilator, and fellows tend to treat it as the one drug you can't overdose. You can. It's a selective pulmonary vasodilator, so yes, you use it to correct hypoxemia and break hypoxic pulmonary vasoconstriction, but it has a clear therapeutic window. Target a pre-ductal saturation of 90 to 97% in term and late preterm babies. Tighten that to 92 to 95 in preterms under 34 weeks, and aim for a PaO2 of 50 to 80. Here's the part that's counterintuitive. Pushing the PaO2 above 80 buys you no additional drop in resistance. Worse, ventilating with 100% oxygen actually blunts the rise in endothelial nitric oxide synthase and upregulates PDE5. So hyperoxia degrades the very pathway you're trying to support, and it generates reactive oxygen species that worsen the redox environment. The observational data from Dallas make it concrete. Babies whose highest PaO2 in the first 12 hours was under 60 did badly, but so did the hyperoxic ones above 200. Both extremes raised mortality. So treat oxygen like any other drug. Dose it to a target and resist the reflex to crank the FiO2 and leave it there. Inhaled nitric oxide is the workhorse and the standard of care, so let's be precise about using it. Start it when the oxygenation index sits around 15 to 20, despite genuinely optimized ventilation and recruitment, not before you've recruited the lung. The starting dose is 20 parts per million, full stop. Going higher doesn't give you more vasodilation, it just adds methemoglobinemia and nitrogen dioxide exposure. Define your responder carefully. The classic threshold is a rise in PaO2, or in the PaO2 to FiO2 ratio of at least 20, but pair that with the hemodynamic picture, perfusion, blood pressure, the echo. A baby whose number ticked up but who's still in shock isn't really responding. Now, weaning, because this is where rebound bites people. Once you're below an FiO2 of 0.6 with a PaO2 at or above 60, start coming down, but in steps. 20 to 10 to 5 to 4, then by 1 part per million every 4 to 6 hours. Abrupt discontinuation causes rebound pulmonary hypertension, and prolonged use suppresses the baby's own endothelial NO synthase, which is another reason to wean deliberately rather than leave them parked on it. 2 practical reminders on the right. Recruit the lung first because nitric oxide follows ventilation and only works in alveoli that are open. And pair it with high-frequency ventilation when there's parenchymal disease. And remember, it's only FDA approved at 34 weeks and above. Here's a slide to change a habit. The classic definition of an INO non-responder was a single number, failure to raise the PaO2 by 20. That's too crude and too late. Read the whole baby instead. 6 signals, any of which should make you think failure and escalate. The oxygenation hasn't improved. The PaO2 to FiO2 ratio won't climb by 20, and there's a persistent lactic acidosis telling you oxygen delivery is still inadequate. You can't get the pre-ductal saturation to 90. The FiO2 won't come down and stay down. There's a persistent gap of more than 5% between the pre-ductal and post-ductal saturations, which is the shunt still running. The baby is hypotensive, and you're climbing the inotrope ladder to hold pressure. And on echo, the right ventricle is deteriorating. Worsening function, more tricuspid regurgitation, a falling TAPSE. The point is integrative. Don't sit and wait for one threshold to be crossed while the oxygenation index marches toward 40. Any of these patterns means it's time to add a second agent or rethink, and to start the ECMO conversation early rather than late. This is the whole talk on one slide. The order of operations you can carry into a resuscitation. Step 1, before anything else, stabilize. Oxygen to target, gentle ventilation, recruit the lung, surfactant if there's parenchymal disease, support the systemic pressure, and chase the underlying cause. Step 2, when the oxygenation index passes 15 despite all that, start inhaled nitric oxide at 20 parts per million. That's your first line. Step 3, if the OI climbs past 25, you're in severe territory, and you add a second line agent. Sildenafil by mouth or IV, inhaled iloprost, and if the baby responds, you can move toward treprostinil for its convenient subcutaneous dosing. Now, 2 parallel branches that depend on the heart. If there's right or left ventricular dysfunction, Milrinone is the smart add because it's a PDE3 inhibitor that gives you pulmonary vasodilation plus inotropy plus improved diastolic relaxation. And if the problem is right ventricular failure against a restrictive ductus, consider prostaglandin E1 to reopen the ductus as a pop-off valve for the strained right ventricle. If the baby stays refractory through all of that,
Bosentan is your third-line endothelin antagonist. And when the OI is over 40 to 45, or the baby is hemodynamically falling apart, it's ECMO. And the recurring theme is to start that conversation early while you still have time, not at the moment of the crash.
After nitric oxide, sildenafil has the best quality of evidence, and in resource-limited settings without access to INO or ECMO, it's often the first and only pulmonary vasodilator available, which matters for many of the units some of you will work in. Mechanism is clean. It inhibits PDE5, so it stops the breakdown of cyclic GMP and prolongs the nitric oxide signal. That's also why it pairs conceptually with INO. Dosing. The IV route is preferred in the critically ill because enteral absorption is unpredictable. Load 0.42 milligrams per kilo over 3 hours, then run 0.07 per kilo per hour. Enterally, it's 1 to 2 milligrams per kilo every 6 to 8 hours. The single most important practical point is that sildenafil vasodilates the systemic circulation too, so hypotension is the real risk. Give the IV form as a slow infusion to blunt that. It's a strong choice when there's significant right-to-left shunting, and it works whether or not the baby had nitric oxide first. Be honest about the adjunct question, though. Adding sildenafil to INO has not clearly proven extra benefit, and a phase 3 trial at a lower dose mainly produced more hypotension. And keep the FDA warning in mind. The higher mortality signal came from a high-dose pediatric trial in older children, so weigh risks and benefits. Tadalafil, on the right, is the same PDE5 mechanism with a much longer half-life. So it's once daily, roughly as effective with possibly fewer side effects, but the neonatal data are thinner, and it's mostly being explored in BPD-related pulmonary hypertension.
Milrinone is the agent to reach for when the heart is the limiting problem, and fellows often underuse it. It's a PDE3 inhibitor, so it raises cyclic AMP, and that gives you 3 effects at once, which is why we call it an inodilator. It vasodilates the pulmonary circulation, it's an inotrope that improves contractility and cardiac output, and it's a lusitrope that improves the ventricle's diastolic relaxation. Think of it specifically in the baby where INO is contraindicated or unhelpful. Low cardiac output from left ventricular dysfunction, or pulmonary venous hypertension from high left atrial pressure, where pure pulmonary vasodilation could actually flood a failing left heart. On dosing, in term babies, run a maintenance of 0.25 to 0.75 micrograms per kilo per minute, and the practical teaching point is to prefer no loading dose, because the bolus is where the hypotension comes from. In preterms under 30 weeks, lower it to 0.2. If the systemic pressure is already low, definitely skip the load. It's a genuinely useful alternative in INO non-responders before you commit to ECMO, and it has a specific role in congenital diaphragmatic hernia, where it improves both oxygenation and right ventricular function.
The prostaglandins work through the prostacyclin to cyclic AMP pathway, and the overarching practical rule is to prefer the inhaled forms. Inhaled delivery avoids the systemic hypotension you get with IV. It deposits drug in the ventilated parts of the lung, so it improves VQ matching, and unlike systemic agents, it keeps working even when there's a big right-to-left shunt. 4 agents to know. Iloprost is the inhaled workhorse. A half-life of 20 to 30 minutes lets you dose it intermittently, term babies respond, it's well tolerated, and hypotension is really only an IV problem. The catch in the US right now is that the delivery system isn't available. Epoprostenol has an extremely short half-life of about 6 minutes, so it has to run continuously, the aerosolized route is preferred, and the rule you cannot forget is never stop it abruptly, because you'll get rebound pulmonary hypertension. The newer Velletri formulation uses an arginine buffer and can be diluted in saline. Treprostinol is the one that's gaining ground, a stable analog you can give subcutaneously, which means no central line, even home therapy, and it reduces pH severity in CDH. And then prostaglandin E1, alprostadol, which plays a completely different game. Instead of dilating the lung, it keeps the ductus open as a pop-off valve for a failing right ventricle. So its niche is right ventricular failure against a restrictive ductus, with the caveat that reopening the ductus can increase the right-to-left shunt and transiently worsen hypoxemia. So it's a considered move, not a reflex. 3 things to close the pharmacology. Bosentan is your third-line agent, an oral endothelin receptor antagonist that blocks both the A and B receptors. It can help in centers without nitric oxide, But be realistic about it. It's enteral and slow, taking around 5 days to reach steady state, so it's not a rescue drug. And as an add-on to INO, the Future 4 trial found no added benefit. Monitor liver function tests and watch for anemia and peripheral edema. The middle column is the horizon, agents you should recognize but not reach for. L-citrulline as an eNOS substrate, the soluble guanylate cyclase drugs riociguat and sinosiguat, rosiglitazone working on vascular remodeling, and metformin in preclinical work. They're investigational, know the names. And finally, ECMO, the rescue. The triggers are an oxygenation index above 40 to 45 on serial gases, or significant hemodynamic compromise. The single most important behavior, and I'll say it one more time because it saves babies, have the ECMO conversation early, at the point of nitric oxide failure, when you have time to transfer and cannulate in a controlled way, not in the middle of a crash. PPHN is the diagnosis behind about a fifth of all neonatal ECMO runs, so this is a pathway you will use.
Let's land it with the 6 things to carry to the bedside. 1. You stabilize before you vasodilate. Oxygen to target, recruit the lung, support the systemic pressure above the pulmonary, and fix the underlying cause. 2. Once the oxygenation index passes 15, start nitric oxide at 20 and judge the response on the whole baby, oxygenation and hemodynamics together, not a single pay-2 number. 3. When the OI passes 25, you're in severe disease, so add a second-line agent, sildenafil or inhaled iloprost, moving to treprostinil if there's a response. 4. If the heart is the problem, Milrinone earns its place as an inodilator. And if it's right ventricular failure against a restrictive ductus, prostaglandin E1 keeps that ductus open as a pop-off. 5. Refractory disease goes to bosentan as third line, and an OI over 40 to 45 or hemodynamic collapse goes to ECMO, discussed early, not at the crash. 6. The safety habit. Wean nitric oxide in steps to dodge rebound, and never abruptly stop epoprostenol. Master those 6 and you can manage the great majority of PPHN rationally. Thank you. Happy to take questions.